Thermal ablation of renal cell carcinoma. Thermal ablation, including cryoablation and radiofrequency ablation, have emerged as an alternative kidney sparing treatment option for small, less than 3 centimeter tumors. Both can be administered percutaneously or with laparoscopic exposure, and thus offer the potential for reduced morbidity and more rapid recovery compared with partial nephrectomy and radical nephrectomy. The overall rate of complication ranging from 7 to 20%, with a low rate of major complications that compares favorably with partial nephrectomy. However, long-term efficacy of this thermal ablation has not been well established when compared to surgical excision, with the data suggesting that local recurrence or persistent rates were significantly higher in this thermal ablation, like 10 to 20%, that are reported with the partial nephrectomy and radical nephrectomy. Contemporary series with the Mayo Clinic recently reported the largest experience with the thermal ablation, with a median follow-up of 5 years, noting no significant difference in the oncological outcome for T1A renal masses when thermal ablation was compared to partial nephrectomy. And the ideal candidates for thermal ablations are patients with the advanced age and significant comorbidities who prefer proactive approach like on over surveillance, but are not optimal candidate for conventional surgery. Patient with the local recurrence after previous kidney sparing treatment for partial nephrectomy or thermal ablation, and patients with a hereditary RCC who present with the multifocal lesions for which multiple partial nephrectomy might be placed their renal unit and therefore function at risk. Patient preference must also be considered, as some patients not fitting this criteria may select this thermal ablation after balanced counseling about the current status of the modalities. Tumor size and locations, they are important factors in patient selection because the current technology does not allow for reliable treatment for lesion more than 4 centimeter and those that are very anterior. Success rates appears to be highest for posterior tumor less than 3 centimeters. So posterior tumor less than 3 centimeter, they are benefited with thermal ablation. Clinical experience and follow-up of patients after renal cryosurgery suggests successful local control in about 85 to 90% of the patient, although many studies provide limited and often incomplete follow-up. Diagnosis of renal recurrence after thermal ablation can be challenging because evolving fibrosis within the tumor bed can be difficult to differentiate from residual cancer. In general, central deep nodular enhancement within the tumor bed on extended follow-up has been considered diagnostic of local recurrence, while peripheral enhancement is intermediate and should be followed closely with repeat imaging. Another findings that suggest local recurrence include failure of the treated lesions to regress over time, progression or increase in the size of ablated neoplasm, new nodularity around the treated zone, and enhancement of the deep margin of the ablated lesion, satellite or port site lesion. And these features are found, biopsy and possible retreatment should be considered. And in 2020 AUA guidelines for surveillance after this thermal ablation include cross-sectional scanning, CT, MRI, with or without IV contrast, and 6 months following ablation, annually for 5 years thereafter, and follow-up after 5 years. A shared decision between the physician and patient, weighing the risk for this RCC, effectiveness of ablation, and patient comparing risk. And more mature data from the limited number of studies now provide encouraging outcome for smaller tumors, particularly those with less than 3 centimeter. Yet the cumulative experience continues to suggest that local control after cryoablation remains suboptimal when compared to surgical excision. And a meta-analysis available data found rate of local control persistence or progression is 9.4% after thermal ablation compared to 0.4% after partial nephrectomy. Although this difference is mitigated when considering the both primary and salvage thermal ablation, both ASCO and AUA guidelines indicate that thermal ablation is alternate approach for management of T1A lesions less than 3 cm in size. AUA guidelines add that for patients who elect thermal ablation and percutaneous technique is preferred over surgical approach. whenever feasible to minimize morbidity. Percutaneous displacement technique using hydrodissection, carbon dioxide or spacer balloon frequently enables separation of the adjacent structure from the anticipated zone of ablation, rendering many cases suitable for percutaneous ablation. Other concerns with this thermal ablation relate to the surgical salvage and potential morbidity. Most local recurrence can be salvaged with repeat ablation, but some patients with progressive disease eventually require surgical extirpation. Partial nephrectomy, minimal invasive approach are occasionally precluded in this setting due to extensive fibrotic reaction induced by this thermal ablation. As expected, the incidence of treatment failure or complication after thermal ablation correlates with the tumor factor, including tumor size and central tumor location, patient factors such as prior myocardial infarction and diabetes mellitus. Other new technologies such as high intensity focus ultrasound and frameless image guided radiosurgical treatment, stereotactic body radiation therapy are also under development and may allow extracorporeal treatment of renal tumor in the future. Thank you.